So it's a privilege to be here. I'm here because Rich Fisher invited me, and I said yes. Like you, I've been using bondable materials forever, and because they're bondable or they're curable with light, we're under the impression that we're actually sticking them to the tooth, and that's not exactly so. But we're all idealists, and we think that because they have the capability to bond, that there should be a way to use them like super glue to glue the tooth back together again. And that's what biomimetic dentistry is all about. Unfortunately, the dispersal or the dissemination of this information is not so efficient in the United States, but it is in Europe and in South America and in Asia. So we're kind of behind the curve on this. There are several dental schools in Europe where you can graduate without having done a crown because they know adhesive chemistry. USC this year started or began their freshman class based on purely adhesive dentistry. So mechanical retention after 100 years is slowly on the way out. And in 3.5 years, there'll be a graduating class from USC who will be experts in this. You can buy the manual in the bookstore, authored by Pascal Mon, and you can start reading it now, or you can come to a class that I'll be teaching at Phil's, or come to the Academy of Biomimetic Dentistry. If you'll Google that, we have a big conference coming up in October where 3 of the heavy hitters in adhesive chemistry research, Junji Tagami, Pascal Mon, and Didier Dichi, will be speaking. First time they've all been on the same platform. Junji Tagami is head of TMDU, Tokyo Medical Dental University. He's the Dean of Research. His department has 200 PhD grad students, all studying dental materials. That's a lot of research. Pascal Mon and Didier Dichi are from Switzerland, although Pascal's now on faculty down at USC. So, and I'm privileged to speak to you guys because you're the ones who taken a step out into the dark by saying amalgam's crap. And now I'm going to give you, after this lecture, now you have a reason for saying that, but not going to jail. Because you can say amalgam's crap from a purely engineering perspective and be right. And if the board comes after you, all you have to do is give them an Engineering 101 textbook and say, you know, go fly a kite. So we'll see if this thing works. So what we're going to learn today or talk about 5 ways to distinguish decay. All of us gray-haired people learn 2 ways only in dental school. There are 3 more that you need to be using. How much decay you can afford to leave in a tooth and still bond and have a durable and stable bond. A 4-step analysis on how to interpret or analyze for structural integrity in your tooth structure. And that will determine whether you're going to restore the tooth directly with direct composite or whether you're going to do it indirectly and take an impression and make your restoration on the lab bench. Simple classification system for bonding systems. You don't have to memorize 27 generations of adhesive materials. Just learn 3 different types. Everything fits into that paradigm. We're going to go over how bonding systems work and the implications. All of this is to take the mystery out of it. Gold standard total etch and self-etch systems. They're 4. Use them on the worst day of your life. They'll still work if you use them right. You're going to learn about host enzymes that are responsible for bond loss. If you don't treat MMPs, matrix metalloproteinases, you'll suffer a 50% loss of bond strength in less than 10 years. Because of that, the insurance industry's actuarial data shows that Class 2 restorations on average are replaced in 4.7 years. And you know from your insurance, you get to do a new one every 2 years. They'll pay for a new one. Okay? It's not the material's fault, and it's not our fault because no one's told you. And it's hard to get the information because the dental materials company skew their data so that their stuff looks good, which, you know, everyone does. But their job is to sell material, not tell you how to make it successful in the tooth. Why direct cure, DC cure composites don't bond to self-adhesive systems. okay? Unless the manufacturer specifically tells you that their system works, if you're using a self-etching adhesive system, it will not bond to a dual cure system unless you do one thing. So stay to the end, I'll tell you what that is. How to overcome number 8 so that they do, because they will. 3 boilerplate luting systems or agents, not cements. So in the old days when we learned zinc phosphate cement, that was a filler. It took up the space between the inside of the crown and the tooth prep. And we were tested on how snug a fit our casting could achieve, because that was key, and gold foil was the standard, right? Okay, so we have adhesive cements. They're all based on glass ionomers. We'll show a study that, a leakage study that might persuade you to consider luting or gluing your restorations on, not cementing them. Our Pope of, I shouldn't say that, our emissary of dental education, Gordon Christensen, was out at my county dental society 2009. The reason he likes cements is because it's so easy to take the crowns off after 8 years. So I raised my hand and asked them, why, doctor, are you removing them after 8 years? And this was why he doesn't like Panavia. It was because it was too hard to get the crown off at 8 years if he used Panavia. So if the cement is failing easily at 8 years to make it easy to get the crown off, to retreat the decay that you have underneath it, why don't you want to use the stuff that's hard to get off because there isn't any leakage? How to avoid and eliminate sensitivity that is predictable, okay? And it's biologically based, and starting on Monday, you can achieve that. And how to avoid endo, because if you don't do mechanical retention dentistry anymore, your level of doing endo is going to drop to 0 on your new restorations, your new treatment. There's still plenty of crowns running around out there that are going to go to endo, because the day you do a crown, there's a 3% risk annually that you're going to suffer irreversible pulpitis. That's an unpublished study from Van Thompson out of NYU. So we just heard a lecture on why you don't want to have endodontically treated teeth unless you've taken Phil Mollica's course on ozone, in which case your endo is sterile. And you won't suffer bond failure either. So my mantra is get bonded and stay bonded. That's biomimetics. Putting the light on the stuff is just curing the stuff. It doesn't guarantee a bond, and it doesn't guarantee a bond under function. So you all know, we all agree that amalgam is bad because it's mercury, but it's illegal for me to say that in California. I'll lose my license. I can agree with you, but I can't tell you that. But let's see. But I can tell you it's crappy engineering. And that's why you should have it out, because you've changed the biomechanics of the tooth as a structural unit, and now you're going to lead to fracture in a traditional world that will be crowned, which is going to impinge or encroach upon the pulpal space and lead to root canal treatment. So let's keep things vital and happy and glue. So here's this week's, some of my cases from this week. What you're going to notice is how flat the preps are. So this is a major paradigm brain tweak twist for everyone, is that flat is best. And so now you're going to say, well, how does it stay on? Well, obviously it's not through mechanical retention. That's how good adhesives are. We'll see a study later on, okay? That has a little axial reduction, but it's a crappy mechanical retention prep, and it would be a do-over in dental school, or I'd be in the 17% of who failed the senior year at USC a couple of years ago. Here's another flat prep. 2 flat preps. Okay, this is the Ruefenacht temporary. I don't put temporaries on things anymore because why bother? They're not sensitive and the teeth don't move much, no more than they do for full coverage crowns. And the white is just a little SRO, radio opaque composite from Danville, so I can see it to tack it so I get less mesial distal drift. I was doing temporaries for about a month and they kept falling off, and I figured The patient's not complaining of pain, so why am I putting temporaries on this? Well, we did that with full coverage crowns because we didn't have the ability to adhesively seal or seal the dental tubules, which resulted in postoperative pain. But with adhesives, you seal, there's no postoperative pain. There's no ingress of bacteria. The occlusion doesn't change that much. Okay, so that's another heresy, mind tweak. Here is one of those restorations being luted with APX composite that's warmed up so it's all squishing out. And on the back tooth, I used a dual cure flowable composite. They're luted on. They do not come off. It's hard to see. Okay, so there is a restoration, no mechanical retention, bonded in place, no mechanical retention, doesn't come off. Okay, here's one from a couple of months ago. Gary Enterbrink, it was a 12 or 13-year researcher for Ivoclar Vivident. He's an American by training. When he lectures, he notes that if you have 1 square millimeter of etched enamel, it had properly bonded, its greater retentive value than 3 millimeters of ferrule with a conventional cement. That's how strong adhesives are on etched enamel. And enamel's king. You can still get the same bond strengths to dentin, but you got to be a little patient and do some things. So the days of the adhesives are here. There's no reason to do mechanical retention dentistry. 100 years ago, if you wanted to put a new chewing surface on the tooth, there was no way to glue it on. We've got it. You're doing veneers, it's the same chemistry. And your veneers are not falling off, are they? And hopefully they're bonded in enamel and not dentin, and you're not over prep. Adhesives are here to stay and they work. The issue is having the understanding to make them work in the oral environment. Okay, so this is HDMAX, a bio-based buildup with composite on the dentin, and then dual cure flowable. So actually, the restoration here, there's 2 bonding systems. There's a bonding system for the EMAX, there's a bonding system on the tooth, and then our luting agent is the bonding system that mates the 2 together. Sometimes they're all the same, most of the time they're not. So know your materials. Dental materials in dental school for me was boring. Creep, flow, and crystal structure formation and amalgam, okay? Hated it. Now I've turned into a geek, and Phil's here to keep me from speaking too much geek. Because dental materials is where it's at. You got to know some adhesive chemistry, and you got to know your substrate, and you got to know how they interact. The only thing I needed to know in dental school about dentin was stay away from the pulp, and use what was that acetone-based, and paint everything with copalite. I love the smell of copalite. Okay, that's all I needed to know about the biology of tooth structure. It was shape, 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 shape. Dental school taught us to be a handheld machinist. Our vertical lathe, or our vertical, what's the name of the piece of our vertical milling machine was our handpiece. And what the dental boards tested us on was the ability to cut square corners. Okay, that's it. And you use some cement to glue your cast restoration on. We were machinists. Adhesives require you to be a bioengineer, to think differently. Okay, so here's an extreme case. Patient of mine, old lady, doesn't brush very well, doesn't have many teeth. She needs this one because her partial sits on it. It's one of her only back teeth. So she's had endo. Tooth fractured off level with the gingiva and not much gingiva. So you're going to do crown lengthening or an implant in an almost 80 woman? No, you're not. I mean, you can glue it back together and it works just fine. First, you got to get rid of all the bacterially infected dentin, and then you got to do your buildup. And I'm sorry, the light's so poor. Posts are out. Caputo back in '84 wrote a very nice textbook that no one's read on the stress generated by cemented posts. So what we do is use, again, resins impregnated with or infiltrated with polyethylene mesh, which is ribboned, in order to do a bunch of things. But anyway, that's the buildup with flowable, and you can't, so you can see a little piece of ribbon sticking out of this soup of buildup material. And now it's kind of rounded, no mechanical retention, no, let's see, it hasn't been refined yet. And Asthenia is a laboratory cured composite made by Carrare. It was sold for about a year in the United States, but Carrare got afraid of a couple of vocal lecturers in the United States and didn't want their material salvaged, although it accounts for more than 50% of the restorations in Japan, a laboratory cured composite. Okay, so that's the restoration. Her hygiene isn't very good. This is pushing 8 years in service. It works. And that's what it looks like. So here's the endofill. There, you can't see anything there because that's the resin ribbon buildup with the fiber sticking up into the buildup, and that's the Asthenia laboratory cured canal or crown glued on top. It's flat. Another flat prep. Let's see, that one looks kind of not so good because it's not bonded on, so we don't have light transmission between the porcelain and the two structure, but once they're bonded, there's better color. Okay, now I had to take one off. I'm sorry this doesn't show so well because of the light. So what this was an Emax conventional crown. So if you got a crown, you're going to get a crown. But we can do it biomimetically, adhesively, so that it stays on and you don't have bacterial contamination going on underneath. So I started cutting the Emax off. Now, when we cut crowns off, what do we try and do? We cut a slot through it, get your surgical screwdriver out, put it in the slot, twist it, break the cement, hopefully the whole thing comes off, right? Everyday experience? Nod your head, say yes. Yes, thank you. Okay. Pardon? Not just nodding. Thank you. Something to throw at you. Okay, so when you properly bond, you're going to have to grind every molecule off. Okay, so the occlusal portion of the Emax is off, been ground off, and I've removed the lingual. And this line denotes the adhesive interface between the dilithium silicate and the rest of the tooth. Now, what material could you have used with your conventional bonding or cementing system where that would still be on after beating the crap out of the rest of the tooth, getting the porcelain off? It wouldn't. It'd be off. That's how well the stuff works. Okay, I was trying to get fancy and make it disappear slowly. There we go. So, is this boy's cast biomimetic? No. It holds his arm rigidly. That's what mercury silver fillings do to teeth. Teeth are flexible objects. Crowns are inflexible. Metal restorations are inflexible. Now, that's what you want on a broken arm, but you don't want that on your flexible tooth. So, what do we do for a direct restoration? And this is so bright you can't see it. Okay, sorry. So, the first thing we need to do for an indirect restoration is establish a adequate bond layer. Okay, and that's key. And that's your adhesive layer plus 1/2 millimeter of flowable. We'll hit the research later. That's your bond layer. That's key. If you can do that, you can mess everything else up and you'll still have a decent restoration. Okay? Pascal Mann calls this immediate dentin sealing. So within half an hour of cutting the dentin, you've got a bonding system on plus 1/2 millimeter of flowable. Two things. your bonding agent, 1/2 millimeter of microfill flowable. Okay. One of the reasons is that all these materials have an oxygen inhibited layer to them. And unless you cover the adhesive system with something, that surface is unbonded. And your hybrid layer won't form properly because your hybrid layer is at max 5 microns thick. And your oxygen inhibited layer is 20 microns. It's impossible for it to bond. You put the flowable on, shine your light on it. Okay? Then with one, let's see, what do I do? With 1 millimeter increments of composite or less horizontally, replace your dentin. And one of the best dentin replacement materials, at least in terms of performance right now, is APX composite from Carrari, because it has a modulus of elasticity of 16 gigapascals, and dentin is about 12 to 14. So it flexes the same way dentin does. And then at the very end, we replace the enamel with a composite that works like enamel. And Carrari has one. I'm not a shill for Carrari. They just happen to have done the research. Majesty Posterior that has a modulus of elasticity of 22 gigapascals. Now, enamel has a modulus of elasticity of 60 to 70, but the intact tooth is around 21. So Majesty Posterior mimics the intact tooth. Okay. And now an indirect restoration. Okay. Why would you do indirect? Well, the volume of defect is so huge that there's a tremendous amount of polymerization shrinkage to manage. And so it's easier to do that on the lab bench. Now there are some clinicians, one Simone de la Peri in Italy, his patients are willing to sit in the chair for 3 hours while he manages polymerization shrinkage. Mine won't. And I don't get paid enough to do it all in one sitting. So we do it indirect. What's key? The bond layer again. The bond layer is what? Key. Hey, he's listening. He's listening. Okay, it's your adhesive layer, whether it's total etch or self-etch, plus 1/2 millimeter of flowable. Immediate dent and seal, okay? That's your take-home lesson. On Monday, when you start bonding, I don't care what materials you're using, your bond layer plus 1/2 millimeter, let it sit. Okay, then go ahead and restore. No post-operative sensitivity. It doesn't matter. You're thinning it. No, now we're getting into some minutia. There are implications for doing it either way, but both ways work. That's the bottom line, okay? Now that you have your bond layer in, you got a big hole in the tooth, right? Okay. And one of the nice things about biomimetics is all the margins are separate-gingival. They're above the margin, so no more crown lengthening. Oh, darn periodontists. They won't buy you a box of chocolate at the end of the year anymore because you're not going to be sending it to them. Raise the box, raise your margin with our favorite APX composite. Bring the margin up. Now take your impression and bond the chewing surface onto your foundation. And now you have bondable margins, mostly in enamel, where you have fast, strong bonds, and also where you had a deep box form that you've built up with APX composite. That composite has bonded to the tooth, and now it won't pull off. Okay? So the rest of the lecture is why this works, but I want you to understand it up front. Yes, ma'am?
So that margin was below the gum line?
Originally, yes.
Right. And then you rebuilt it with Majesty.
With APX composite, because it behaves like dentin, and deep boxes have no enamel. Right? So this is a case. I'm glad the lights aren't so good because the color match isn't so good. These This lady surprised me and said, I want you to rebuild my mouth. I said, great. And then she said, you only have 3 weeks to do it. So I did the anteriors in composite and the posteriors in 2 visits, a 3rd visit to bond them all on. This is, and everything's still there, and it's been about 6 years. Okay, flat preps. That's removing all the junk that was in her teeth. That's with the biobases in. That's when she came back, no temporaries, no pain. Bonded on. Lab messed me up on this one, had to redo it. And this one. And I don't have, we had a problem with that one and redid it. This doesn't show well, but there's a big crack right there, horizontal. And you can see the shadow from the silver filling in it, mercury filling. See the crack right there? Is that biomimetic, that restoration? No. Why? You already know this intuitively. The tooth is flexing. That isn't what gives the tooth. And on top of that, it was an A student who cut the prep, so he put square corners in the bottom there. Where's stress concentrated? Sharp corners. Tooth doesn't stand a chance. It's going to break. It's not if, it's when. Okay? Napoleonic justice here. Guilty until proven innocent. You see an amalgam, there is a crack until you can prove otherwise. Okay? Silver fillings are cracks. All the time. Here's a little one, and again, the light's really poor, but there's a fracture plane right there. All it takes is a disharmony in the stress distribution pattern of the tooth, of the structure of the tooth, to concentrate stress. It doesn't have to be big. It can be little. So we have a choice. Are we going to fill a hole, or are we going to make the tooth whole? Well, we want to make the tooth whole, and we can do that through adhesives. We can make the tooth think that nothing ever happened to it if we replace each layer in the tooth with an appropriate adhesive that has the mechanical properties of the layer that we're replacing. That's the modulus of elasticity. And that's what USC is teaching, and a few other dental schools are playing with. So again, we want that, not that. This is Civil War dentistry. That's what I call it to my patients, because this is what we were doing 100 years ago when that's all we had. Okay? If someone came to you with carbon fiber, would you say, oh, whoopee, look what a nice buggy whip I can make out of this? No, you wouldn't. You'd say, oh, there's a better way. Oh. So we want to return the tooth with adhesives back to original strength, front to back, side to side, top to bottom. In Europe, they call this bioemulation dentistry. Here in the United States, it's biomimetic. We're trying to mimic the biology or engineering of the tooth. And this is a big paradigm shift in how we think. It takes patients about 15 seconds to figure this out, and it took me 2 years to warm up to the idea. So we all have a shelf full of bondable materials. If you can imagine me in my spandex mountain bike riding costume, and yeah, don't get sick, don't throw up all at once. And my $2,000 mountain bike, would you expect me to be able to do that? No. Or that? No. Maybe this, yes. Okay? So possession doesn't mean equate with results. It can, but it doesn't necessarily mean that. And the problem is, that's the shine rep, and so we say, oh yeah, I'll buy that. And when we ask why, oh, because it handles nicely, it cleans up nicely, it got 3 stars from Reality Magazine, it's strong. But when you look through the literature, when you go back and look at your throwaways, start looking at the ads. There's no science in them at all. It's just opinion. Someone liked it. Well, who? Well, the guy who's getting paid by the company to say, I like it. There are 100 different bonding systems on the market. Okay? It's impossible to know them all. So the literature shows us what the gold standards are, so we stick with those. So curing can mean bonding, and it can mean biomimetics, but curing at its root is just shining a light on something to get polymerization. If we're really bonding, then we're getting adherence of our composite to different substrates, and over time, they stay bonded. That's biomimetics. Our problem is that manufacturers have us captive. They hold all the cards. You and me don't know what's going on because we find it hard to get reliable, concise, understandable information. What's for lunch? Here's the Shine rep. And that's us. Holy bird poop, Batgirl, it's me. I'm for lunch, and I just bought a new system. And I don't know why, other than someone said, well, it's good. But with a little bit of information, we can be like Chesty Puller, my hero from the Korean War. This is a bunch of enemy toy soldiers around a few heroes. He said, so they've got us surrounded good, now we can fire in direction. Those bastards won't get away this time. Those of you, well, Chesty Puller was surrounded at the Chosin Reservoir in Korea with a division. He got them all out. It was because he was a great commander, and he had them prepared. So information prepares us. We're not at the mercy of all the manufacturers and detail people. So, as my friend says, I'd like you to check your belief system at the door. You get to pick it up on the way out. We want to mimic the structural integrity of the tooth, the modulus of elasticity. We want to have good microtensile bond strength. We want to allow for micro movements. We want fracture resistance. We want our restorations to be caries-free, infection-free, and wear-resistant. And biomimetics will do all that. The benefits: as a profession, we conserve pulp or structure. Our endo rate goes to 0. We remove the pathology predictably and quantifiably. We leave a maximum of tooth structure, which the patient likes, so we're tooth banking, so when our stuff eventually fails, and it will, there's still something left to work with instead of extraction, root canal, or partial denture, or edentulous living. We actually strengthen the tooth, and it eliminates sensitivity, which the patient likes. So with this approach, you'll have 24 hours of just minor post-operative sensitivity because it beat up on the tooth, but after that, they don't feel anything at all. All through adhesive dentistry. No graps. We establish, let's see, that's just a review because I like to repeat. Clinically, we're going to determine our carious endpoints. We're going to analyze for structural integrity. We're going to practice immediate dentin sealing and understand polymerization kinetics. We're going to control C factor. Anyone not familiar with the term C factor? Okay, we'll talk about it. And this is an old scouting tool because I'm an old scouter. Instead of asking everyone on the trail, is everyone ready? We ask anyone not ready because I don't care about the ready people. I just want to know who's still tying their shoes. So, and I'm the guy that sits on the front row with all the dumb dentist questions. So I appreciate those of you who are valiant enough to ask questions. So,
I have one really quick before
yes.
Some of your preps look very gross, tooth structure removal. What are they normally like? I mean, some of those that we saw were just...
That's because, yeah, that first case, that was bruxism. That's all she left me with. And so after removing the axial wall above the pulpal floor from the old amalgam, that's what's left. Not much. So in tooth structure, if you, I don't have a good slide of this, but we've got 5 or 6 millimeters of vertical height in tooth before we're into the pulp. So you can whack the occlusal surface down quite a ways before you violate pulp. Axially, you only have 2 or 3 millimeters. At the cervical area of the tooth, or the dentin enamel junction, dentin cementum enamel cementum junction, at the free gingival margin, on a highly tapered or truncated tooth, if you do 1 millimeter or 2 of reduction, so the lab has room for their aesthetic crown, there's no tooth left. You're into the pulp. So you can take it down vertically in a horizontal plane without damaging the pulp. And that's a real mind bender. It took me a couple of years to get used to the idea before I'd even try it. So this is not something I learned about one day and did the next. Yes?
Sorry, you mentioned earlier the average lifespan of a composite.
Yes.
4.7 years.
That's insurance company actuarial data that they won't publish, but
Right. But essentially what we're doing is bonding these things on like composites. So why is this lasting longer than 4.7 years?
that's the rest of the lecture. So, if you understand, we're just going to buzz through this because I don't want to run over. Is it time for the break yet? Tea time? Okay.
You're scheduled to go through to 4:30. If you want to take a break down the road, that's fine. Otherwise, it's just
15
be
minutes and then you come back in 15 minutes.
Okay. We put all these things, these 6 points together, determining carious endpoints, identifying structural integrity, immediate dent and sealing, understanding your adhesive system, polymerization kinetics, understanding and managing C factor. Number 5, proper restoration design, on-lay or full coverage, and then managing occlusal forces. You have stable bonds that last a long time. It will fail, because everything we do is going to fail. When it does, you'll be able to fix it, you'll be able to see it sooner, and the person still has a vital tooth. Okay? Break time. Yeah, but it's break time. Get up and have a drink, stretch.